Welcome to Aetcm YouTube channel. So today we are going to discuss regarding a trauma patient. Basically, this patient had a chest injury. So we'll discuss the case. We have Professor Dhansegaran sir with us, and Dr. Riaz and Dr. Vivek, and Dr. Riaz will be presenting the case. Over to you, Riaz.
Thank you, sir. Sir, a middle-aged man was brought with an alleged history of road traffic accident. And in my initial 10-second assessment, patient was conscious oriented, and he was able to completely respond to my commands. So immediately I started my primary survey. In primary survey, I checked the airway. Airway appears patent. He is able to completely respond to my proper verbal output was there. No oral secretion, no tongue fall. And I went to the cervical spine. No cervical tenderness or no movement restrictions were present at that time, sir. Then I went to the breathing part.
Still, you want to do cervical spine immobilization?
Yes, sir. Ideally, as per ATLS algorithm, unless and otherwise you can X-ray to rule out a cervical spine injury, we should always go for a Philadelphia collar and secure the airways.
Heart collar. Whatever is available, you use a heart collar.
Cervical collar. Yes, sir. This patient actually from the outside the ambulance itself, he was having a cervical collar. Okay. So actually we retained the cervical collar, sir. But on examination there was no movement restrictions, sir. But anyway we continued till the imagings were done, sir. Then I went to the breathing part. In breathing part, the patient was maintaining a saturation of 95% in room air with a respiratory rate of around 22 breaths per minute. And on auscultation, the air entry was slightly reduced on the right side, sir. Okay. And the patient was also complaining mild pain over the entire right upper quadrant part of the chest. Okay. So at this point, I already secured a 2 large IBO cannula, and immediately I asked for an adjunct. An X-ray chest was already ordered, sir.
Anything else will you take care in the breathing assessment of breathing?
Yes, sir. One thing is that we can go breathing 94% is maintaining and
95% is maintaining.
Okay. That's why I didn't start him on oxygen, or else if we could have started him on O2. Okay. And one thing I can do is that since it's a trauma patient, we have to rule out a pneumothorax or a hemothorax.
No, you told about the rate.
Yes, sir.
See, anything else near particular element of the assessment?
Respirator is around 22 only, sir, and pattern was also almost appearing normal, sir.
Pattern and chest excursions, more important thing. So that only will be giving an idea that whether the patient has got adequate ventilation or not. There may be hypo or apnea or irregular respiration. So saturation maintenance is another thing. So this one, and then symmetrical chest movement, hemithorax, and in the same hemithorax, you have to see any regional abnormalities. Yeah, these are all the things.
For this patient, but this whole movement appeared to be normal only.
See, never say appear to be. Always be precise. It is okay or not. Airway appears to be, it will not be counted. So airway is normal.
Airway
Never say equivocal words. Okay, appear to be, and all we have to better avoid.
Over this area, we will go for palpitation and all. Here, this area he was having mild tenderness. Otherwise, but he is having a regular respiratory pattern, and he appeared to be stable, sir.
Ventilatory excursions is of primary importance.
Yes, but he was not having a severe exertion on respiration. So anyway, at this point, anyway, I have and since we suspected decreased air entry, we have asked for an X-ray chest was asked, and along with a screening lung ultrasound was done with our probe, ultrasound probe, and in the screening ultrasound, we were able to actually we got a bilateral the lung sliding scale was present, but when I came to the axillary area on the right side, it was slightly decreased. So we were suspecting some actually the seashore sign was absent on the right infraxillary area, and there was no effusion, sir. There was no collection of fluids, nothing was there. And then I went anyway breathing part. Right now, since he is stable, I was waiting for the X-ray chest. I then went to the circulation part. Circulation, he was maintaining of BP of around 128 per 78 millimeters of mercury with a rate of 98 per minute. Anyway, right now this 98 I possibly because of probably he is having pain over that area, and then circulation, peripheral pulses were present, no severe no external bleeding sites were present at that time. Then I went to the disability part. GCS was 15/15 with 2.5 mm bilaterally reactive pupils, sir. Then Then at that time I assessed the pain scale also. I gave a numerical scale of 10 and he was scoring of around 7 out of 10. So I gave an analgesic at that time since he was having severe pain over the right side. So I gave him an fentanyl was given, 1 microgram fentanyl was given with Nemicid was given for analgesia, sir. Then coming to exposure, his peripheries appear to be warm and GRBs also were within normal limits, sir. So I again reassessed the primary survey.
Disability?
GCS was full, sir. Pupils 2.5 mm bilaterally reactive.
Okay.
That time only we assessed the pain scale also. Okay. Then I again reassessed the primary survey. Airway is still patent. Breathing, still he is maintaining a respiratory rate of 22. Saturation 94 he is maintaining. Intermittently in the range of 94 to 97 it is still maintaining. No worsening of respiratory pattern. He appears to be stable. And by the time I got an X-ray chest that time, and X-ray chest was having a right-sided elevated hemidiaphragm was noted at that time, sir. But otherwise we were not able to appreciate any rib fractures, and no BVS pneumothorax or effusion signs were not present at that time. But we were able to know suspected fracture of the right clavicle was there at that time, and so we thought of the possible pain is possibly due to the clavicle fracture. Since he was complaining of pain over the chest, we go ahead with the ECG was also taken to rule out any MI nothing, but ECG was also within normal limit, and to rule out large vessel injuries, screening ultrasound was echo was also done in the ER, but we were able to with the visible area we were able to see the arch of aorta, and the screening large vessels were able to see, but it is also within normal limits. No pericardial effusion or tamponade were noted. So
elevated hemidiaphragm, right side elevated hemidiaphragm. So what are you suspect at this point?
In trauma, in acute scenario, what we have to say is possible a phrenic nerve injury is a possibility, and other thing is that in conditions like lung collapse, we get an hemidiaphragm.
Always whenever you see an abnormal X-ray, like elevated hemidiaphragm, there will be some underlying pathology.
Yes,
for example, in a trauma case, definitely we need to think about an probable phrenic nerve injury and diaphragmatic palsy. That's a priority one. So you got an X-ray, so these were the findings. But meanwhile, you were suspecting a pneumothorax.
I mean, because the ultrasound in lung sliding scale were absent to the right lower borders.
Throughout hemodynamically maintained.
As well as saturation maintained. No respiratory worsening, dyspnea. Nothing was there.
If this person worsened, what would have been your?
Sir, first thing that I would have thought is possible the patient going into tension pneumothorax. We will again auscultate if the error is further worsening. Then I will be thinking of a tension pneumothorax. And
if there is hypotension associated right now, when you are not seeing anything else, definitely the priority will be to put a
needle decompression.
Okay.
So possible in adults, as per as the ATLS, it is ideally the site of choice is 5th intercostal space. We can use a 14 gauge cannula along with the water seal syringe has to be taken, and up to 3.5 inch we can go inside and aspirate the air till the bubbles are coming. Unless the patient becomes symptomatically improved, we can do a needle decompression followed by an ICD has to be placed in case of a tension pneumothorax.
Okay. Fine. So you can continue what happened to this patient.
Okay. Following which this patient, a primary survey was reassessed. It appeared to be patent at this time. So and I went to the secondary survey. Secondary survey. Fast was done negative, sir. I mean, abdominal first was negative. In the lung thorax side was suspected. When I did the lung ultrasound itself, I screened for the abdomen also. Respiratory was normal. So I went to the secondary survey. In secondary survey, no history of any allergies, no history of any medications. Past history of hernia surgery alone was there. Then even last meal was yesterday night 8 p.m. sir. And even lead to that patient alleged history of a road traffic accident, bike versus biker. A patient was a rider, following which he has sustained an RTA and he has fell down and he sustained an injury over his right chest, and here is history of a head injury also. but there is no history of an LOC or a seizure or vomiting, and the patient was able to, no retrograde amnesia, patient was able to recollect the entire event, following which he was received by a EMT team with the ambulance, and he was brought to Amrita
The patient
hospital.
was wearing a helmet properly?
Actually, patient was not wearing the helmet, sir.
Okay.
It was at night time. He was not wearing any helmet. And following which he was brought to Amrita. This was the event led to arrival. Then head to foot examination. In head to foot examination, there was a mild contusion over the right occipital area, and then went to, otherwise there was neck appears to be patent, and oral cavity, everything appears to be patent. Pupils are still intact. Then I went to the chest examination. Chest air entry is now persistingly reduced over the right side. Otherwise, saturation he is maintaining with a respiratory rate of 92, and cardiac S1 S2 was already normal. Already a screening echo to rule out any effusion or tamponade was already done in my primary survey. Then went to the abdomen. Per abdomen was soft, non-tender, and already I had done a screening ultrasound to rule out an abdominal injury. Then I went to the pelvis. Pelvic compression test was negative, and then I went to the spine, and in the primary, before receiving the patient in the ED itself, we have already done a screening of the spine, and there was no spine tenderness was there. Then I went to the musculoskeletal examination, moving all four limbs, but pain was associated with the moving of right upper limb. Possible in our X-ray was suspecting a clavicle fracture. It may be because of that, sir. And otherwise, no other, only mild abrasions over the right upper limbs was there, and that too, no active bleeding. No other external injuries were noted, and the perineum were also intact, sir. No bleed in the meatus, nothing was there. And then so I came to the provisional diagnosis that the patient is having a road traffic accident, followed with a mild brain injury, head injury, followed by a right-sided upper chest
injury.
There is a history of head injury in the history, sir. Otherwise,
so do you want to tell mild head injury? What will be a
there should be a mild fall in GCS,
okay.
but right now there is no fall in GCS, sir.
And he's having a head injury, maybe a soft tissue injury,
Soft
I'm not
tissue,
sure. We need to evaluate it. Occipital, some hematoma, something was there. More into a soft tissue, but definitely we need maybe we need a CT brain or maybe later on. As if now you don't have any evidence of any head injury to take an CT, but definitely we can take if it is warranted later on also. So when will you consider a CT in a head injury patient?
Sir,
for all patients you need, or what are the specific signs?
Whenever we have an old age patient, age more than 65, or whenever there is a depressed skull fracture, or whenever there is a fall in GCS, or patients have any features of raised ICT like multiple episodes of vomiting, blurring of vision, anything is there, or any history of LOC lasting for more than 30 minutes.
So any loss of consciousness, any seizure activities, anything in between from the event to the hospital or after coming to the hospital, definitely it is warranted. Or if the patient is in your hospital, again he is developing any signs of raised ICT, definitely yes. Or the patient is on any oral anticoagulants, or aspirin or anything, or clopidogrel or dual antiplatelets. These are all warrants and definitely CT. But many times without any indication, the bystander will insist us to get a run CT. So that is another thing, and definitely whenever you suspect any of these things, you will go ahead with the CT. Otherwise, you can wait and watch, and you can later on proceed with the CT. So there is no harm. So what happened to him?
So electively right now to roll out the CT lung was planned for this patient. Since we are already
thorax,
and he was absolutely hemodynamically stable, so he was fit to be shifted to the CT room.
You are telling that this patient is having a clavicular fracture.
Well, suspected.
Suspected clavicular. You got that in the X-ray. So what are the things when you see a clavicular fracture? What are the other things that you will keep in your mind? Okay, what are the things you need to look into? One is pneumothorax.
One is great vessel injury should be always suspected.
So it's always an upper thoracic injury. Always remember regarding the greater vessel. That is the aortic injury. There is a high prone chance to level for an aortic injury. Especially maybe a blunt chest trauma. There is a high possibility. Maybe it's a concealed hematoma. That's why he is not going into hypotension.
Yes,
so always we need to keep in mind that regarding that. So definitely this patient needs in the secondary evaluation a CT chest to look for any evidence of we have a suspicion of pneumothorax. Pneumothorax we need to rule out. Also the greater vessel injuries we need to screen it. So definitely you need one.
Okay.
So what was happened? What was done to him?
He was taken up for a CT chest. Along with we actually planned for a CT screening. CT brain was also done because anyway we are shifting him to a CT room. So he was hemodynamically stable and his pain has come down with our analgesics. So he was shifted to the CT room, sir. In the CT room, post CT we found to have that the patient is having a right-sided massive pneumothorax.
Right-sided
pneumothorax was there. Along with the CT brain was showing a mild EDH also was there. Noted.
So meanwhile, maybe from the time he came in till the CT room, maybe the pneumothorax has slowly progressing. But he never went into compensation. So that was the main thing. So there was never a desaturation or any hypotension or anything. So he was taken to the CT room and you diagnosed that he is definitely having a pneumothorax. So once you know this, what you will do now?
Now the patient was shifted back to our ER and it's almost the right lung is almost collapsed more than 50%. So you are planning to go ahead with an ICD tube, sir.
The steps of ICD placement.
So placing an ICD tube, one is indication is like in case of a pneumothorax or in case of hemothorax or in the case of empyema, everything we have to go ahead with an ICD. In trauma, pneumothorax are the important things. So we have first we have to identify the triangle of safety. First we have to go with the consent. Consent. We have to explain the procedure to the patient as well as the bystander. We have to get a consent. And another thing is we can go ahead with the consent for procedural sedation also. And next is
so what sedation you will choose?
For this patient, since he doesn't have any coronary artery disease or any other comorbs, ideal agent will be going ahead with a mild amount of midas with the ketamine can be tried, sir. Ketamine around 0.5 mg per kg procedural sedation and midazolam around mg per kg can be given, and along with the proper precautions like oxygen, continuous IV fluid, and along with the backup of intubation, rapid sequence intubation we have to keep, sir. And with this is the planned procedural sedation for this patient, sir. And we have to first identify the triangle of safety for any placement of an ICD.
Positioning the patient?
Position is things like around 45-degree elevation is the one position. Hand position with the hand elevated and kept over behind the head, sir. Or another position is that we can ask the patient to lean forward, but in case of trauma patient it will be difficult and painful, sir. And this patient triangle of safety has to be identified. It is a lateral.
Pneumothorax ICD insertion will be the best hand.
Hand capable.
We are planning to tap only. You can go to the front and we can tap from behind.
And it's another position. So it is the lateral border of the pectoralis major and anterior border of the latissimus dorsi, along with the line joining the nipples or the 15 intercostal space has to be base, and the base of axilla is the another mark. Within this area, it is safe to insert an ICD tube, sir. So along the mid axillary line. So ICD for
anterior to the mid axillary.
Anterior to the anterior area to the mid axillary.
You identify the triangle of safety. You draw the mid axillary line. Anterior to the mid axillary line, either in the fourth or in the fifth intercostal space. In the space,
upper border of lower rib through which we have to enter.
Upper border to prevent
neurovascular bundle injuries, sir. And so we gave him an appropriate, and the selection of tube also is important. For pneumothorax we can go ahead with a lower size tubes like 28 and all. For hemothorax we can prefer a larger size tubes. And one more thing is that we should always have the water seal everything ready, sir. Water seal we have to keep at least 100 ml of water seal has to be ready, and it should be everything should be kept ready, and it should be airtight. So we have to give proper analgesia, local anesthesia while placing an ICD, because the periosteum is very pain sensitive and all. So we can use 2% lignocaine. Up to 3 to 5 mg per kg can be used without adrenaline, and with adrenaline 5 to 7 mg per kg can be administered. We have to give to the parietal pleura and around the periosteum should be given.
Suppose the patient weight is 50 or 60 kilogram. How much do you calculate? How will you load it?
16 to 3 around 180 milligram of one should be
given, the minimum, sir. Side, okay.
Should be given, sir.
ML size.
ML size is 0.3 ml. 2% means 0.3 ml per kg can be calculated.
So each ml will contain how much? 2% means.
2%.
So 0.3 ml will contain how much?
0.3 ml will contain around 5 mg, sir.
2% means what? 2 gram in?
2 gram in 100 ml.
So just simple one thing, 2 and multiply by 10. that is 20. Anything percentage you multiply into 10. That will be the milligram per ml. If it is 0.5 multiply, that will be 5 milligram per ml.
So
2% is 20 milligram per ml. So total you want to give 180.
180.
So how many ml you have to load?
9 ml.
9 ml. Like that easy. Okay.
Okay.
Good.
Always there should not be any confusion. This is we all remember these things all will come in percentage. So we have to convert it. Then everything will come at milligram per kg. So we have to find it out. So that is the easiest formula, sir.
Yeah, multiply by 10.
Whatever be the percentage, multiply by 10. That will be the mg in each ml.
Okay.
Then you can calculate and give that ml accordingly.
So if you give more, what will happen?
More is one is the systemic absorption will be more. Signs of local anesthetic toxicity, cardiac arrhythmias, everything is there, sir.
What are the toxicity? So you are using the local anesthetic. You have to know about what will happen.
Ventricular tachycardia, arrhythmias, everything will be
Cardiac,
there, sir.
any other thing?
Another thing is cerebral.
See, there are two ways the local
seizures.
anesthetic toxicity may manifest. Accidental injection into the vascular tube.
Vascular injury.
So then sudden rise in the blood concentration. Number two, overdosage. Again, the concentration in the blood will be going beyond the therapeutic range. So both the time the same action will be there. Only thing, when the overdosage, the symptoms will be, onset will be very slow. Intravascular injection, immediate onset within seconds to minute. So first it is a cerebral stimulation followed by depression. This is the main action. Apart from cardiac action, main action. So during the stimulation phase, it will produce seizures. So this is a transient episode, then it automatically will settle down. It will be followed by a central depression. So during the central depression, all problems will occur, including the medullary centers depression. So vasomotor center, profound hypotension, bradycardia, respiratory center, patient may go for hypoxia, apnea, all these things will happen.
Okay.
So this we have to be very careful. That is why we want to avoid overdosage, and every time you withdraw and see that before injecting. These are all the two mandatory. How will you manage?
Lipid emulsions, intravenous lipid emulsion.
See, for xylocaine we need not immediately go for. The short life is only 40 to 45 minutes. But there is no antidote at all, only supportive measures. See, take care of the hypotension, take care of the respiratory problem.
Not available.
Okay.
Emulsion is we don't have.
For bupivacaine you can go for. This is the only thing that will directly have a cardiac action.
Yes.
That cannot be reversed easily. So for that, lipid emulsion will be very useful.
It's not freely available. It can be made available.
Yeah, made available.
It is not freely available. It is available.
Support
not freely available.
Okay. Good.
So you have given the local anesthetic.
And after that we have to make an incision with the 11 size blade, around 1.5 centimeter small incision has to be done. Then next step is we have to dilate it. Two options are there: either you can use an artery forceps and make a dilatation, or in our hospital we have already have a dilator trocar is available. In which with a rotational movement we can dilate it, and once we reaches the pleural cavity, but make sure that we don't puncture the lungs again. So a small movement we can with the
guarded
trocar movement.
That is the most important thing. If the trocar is this length, you can keep a finger like this and you can use a guarded trocar. So that without this finger length it will not go inside. So that is the best thing. So you slowly insert and dilate it, and once you enter the pleural cavity, you will feel that gush. And you can stop there, and then you can remove the trocar
and insert the ICD tube till the last hole is around 1.2.5 centimeter inside the chest wall, and we have to see the whether the water seal is connected, and we can open the water seal and see whether the gush of air is there along with the movement of water column is there. Then we have to secure the ICD using a silk, usually 1/0 suture material is used. We have to close the wound site along with the secure the ICD to the normal skin nearby. We have to give a dynoplast should be applied, and we should secure the ICD tube, and we should watch for the water column movement, and we should take a repeat X-ray just to see the position of ICD tube. One more thing is that for pneumothorax we can go the direction of incision can be more of posterior side, and while care of pneumothorax it should be laterally and anterior direction of the tube is advised, sir. And then
What are the complications?
one major complication is that puncturing into the goes into the lung injury, or if you are inserting too much injury to the heart direct into the pericardium is one possibility. Most common complication is the development of bronchopleural fistula. Fistula is the formation.
And subcutaneous emphysema. See, the tube is not, the hole is not exactly inside the pleural cavity. There can be communication from the subcutaneous tissue to the thoracic cavity, the subcutaneous emphysema. These are all things can happen. So that's the main thing. And infection, bleeding, all those things. So this is the major thing. So once the patient, he was placed on an ICD. And what was done for him after that?
Actually, within next repeat X-ray was showing a resolution of the pneumothorax. The initial or suspected pneumothorax was solving. Within the next 3-4 days, the water column movement was stopped, and his lung was fully expanded, and his EDH was conservatively managed. And by 5th day, the ICD was removed, and the area was sutured and secured, sir. And he was symptomatically better, and clavicle also with a figure of 8 bandage, it was also conservatively managed, and the patient was given with proper analgesics, and he was symptomatically better and discharged later, sir.
Okay.
And one more.
Let me ask you one thing. If there is an associated hemothorax also for this patient, so how will you manage now?
Sir, hemothorax again, the management will be going ahead with an ICD placement, everything. But if the initial gush of blood is more than 1.5 liters, then, or if the patient is continuously draining more than 200 ml per hour of fresh blood is again and again coming, it is an indication for open thoracotomy in adult patients. And this patient also, this pleural hemothorax, the blood coming out actually again can be auto transfused also, and that is also one indication, sir. And if there is again.
Let me ask you another question. If the patient has come with a penetrating chest injury.
Yes, sir.
Okay. So where you place the ICD?
Penetrating chest injury.
There should not be any confusion. It should be the same
area.
Triangle of safety.
Triangle of safety.
You seal off and you do the patient has to be taken for a thoracotomy. Yes, maybe definitely penetrating injury, they need to do the management for that. But ICD placement is in the triangle of safety itself. You should not be using the same track. That is some places they have been using mistake. They will be using the same track, the penetrating track itself to put the ICD, because the chance of infection is more. You go to the triangle of safety and you put your ICD and you do the basic management of the penetrating wound. Yes, so we have an open pneumothorax. Yes, so what is the first step that you do?
One thing is that we have to close that area using a plastic bag in which 3 areas can be covered and 1 area can be kept open, sir, so that it will act as a valve. That's the first thing we have to be done, sir.
Okay. Ideally, it will be aluminum foil if it is available. If it is not available, you can use whatever thing to close it off, but seal off only 3 areas. You keep 1 area open. Okay, so that is a 3-way adhesive bandage.
Yes, sir.
So that is the next thing that you need to remember. Okay, so if the patient has, the same patient had come, he had come with full GCS. Now we are suspecting a thoracic injury and he has come pulseless cardiac arrest. That is the reason come in cardiac arrest. So what will you do at this time?
Cardiac arrest means again we have to
traumatic cardiac arrest, secondary to chest injury.
We have to initiate CPR as well as ACLS algorithm. But one thing is that we can go ahead with an ED thoracotomy.
That is one of the indications.
We
have not practiced till date in our ED, but that is definitely one of the indication for an ED thoracotomy. So you have life-threatening injuries. Whenever you say life-threatening injuries, the major life-threatening injuries are?
One is cardiac tamponade, great vessel injury, tension pneumothorax, massive hemothorax. These are the major chest life-threatening injuries.
So those are all not life-threatening, but they can be life-threatening if not managed properly. Do you want to give any antibiotics to this patient?
Sir, usually not required in this scenario in case it is a clean wound, everything. But if you are suspecting a open wound infection, or if it is a contaminated wound, then ideally an antibiotic coverage can be given. Sir.
Maybe a gram-positive coverage can be anaerobic if it is contaminated. We can think of that. Tetanus prophylaxis?
Of course, sir. We have to give a tetanus prophylaxis for this patient. Sir.
Tetanus prophylaxis. It is actually there is no tetanus-prone wound in this patient. We are only surgically creating a wound, but maybe you can give. There is no contraindication to give, but definitely it is not 100% indicated. Immunoglobulin definitely not. So there is no need for any tetanus immunoglobulin. Okay, so again you have a scenario where this patient have a massive EDH. Okay, massive EDH. He is in a facility. He is in a remote facility. You want to shift him. to some other center, and you're taken a similarly the situation, you don't have a CT facility, you have a suspicion that there can be a pneumothorax. So what will be your management plan change? You are in a remote facility, there is no other further CT, you don't have anything else, you just got your chest X-ray done, but he need to be transported to some other area in a normal ambulance or whatever be this. So what will be your plan? Do you want to put an ICD and send him?
Ideally, we should put an ICD and send.
That is again a question. It's taking how long, and who is going to accompany? What are things that you can do inside the ambulance? If the patient is going to be airlifted, definitely yes.
Yes.
That is a scenario we are not practicing, but still you need to understand that if the same patient is some other remote facility, you want to transfer him. If you are suspecting a pneumothorax, definitely he should be having an ICD. When it is airlifting 100%, in other situation, preferably yes, because whenever you have suspicion, he should not develop a tension pneumothorax inside the ambulance. And work to manage, put an ICD will be extremely difficult. So it is whenever you have a suspicion like this, when you don't have any other facility, you have like an elevated hemidiaphragm, maybe you are thinking that there can be a pneumothorax clinically, you can go ahead and put an ICD and then refer him, rather than waiting and let him deteriorating inside the ambulance. So that will be the next thing. Definitely air ambulance, yes, because the scenario being the India is getting developed so faster, the scenario is not very far away. Anytime this can happen. So whenever you have that, definitely an ICD needed to be placed.
Yes.
Okay, yes, that was a very good discussion. Thank you.
I have one more few questions. Okay. Suppose the same patient is coming with a tension pneumothorax or suspected tension pneumothorax, and the respiration part, you are not happy, you are planning for a rapid sequence intubation or a within as much as early you want to go for an intubation. What are all the precautions you have to keep in mind?
Same patient deteriorated.
Okay, sir.
Okay.
As soon as possible, actually tension pneumothorax, we should try to reduce the decompression as well as possible. So we have to immediately do the needle compression, and the ICD should be emergently planned while going with the rapid sequence intubation itself, because this positive pressure itself can worsen the pneumothorax.
Before intubation you have to place decompression. Okay, good. Very good.
And we should definitely place an ICD if you are going with a positive pressure ventilation.
Okay. Suppose as sir was telling, in a remote place you are there and you are sending the patient in an ambulance, so you may not be going. What are the instructions you will give for the accompanying paramedical or nurse?
Thing is that always watch for the water movement of the column, and always keep the water seal below the level of the lungs. These two things are most important.
That is a common error that these people do. They just clamp it off. That should never be done.
It should be kept off.
And it should be below the level of the chest.
And make sure that it doesn't come out. It should be
anchored well.
Anchored well.
That should be there. And monitoring of the patient clinical status closely.
Yes.
That is the main thing.
Anything else?
No, good presentation, done well.
Thank you.